I myself enjoyed it quite profoundly. I have to thank our two guests, Professor Natalie and Robin, for their effort and their lectures. I find it very good, very helpful to listen to pick others' brain, to know what their expertise are, especially if they are working in a little bit of different arena and a different set of patients. I think that Natalie is working on a chronic disease patient very large in ICU, and somebody from US and from Harvard Medical School will just enlighten and enrich our experience. I have to be grateful as well for Rania Karas, because she is the one who has been the dynamo behind all these 3 days. Thank the audience who have waited the 3 days, and the company who make this happen. And we'll start with the last session.
Thank you very much. Is that okay? Now it's fine. Thank you all again. It's been so wonderful to be here. Everybody is so welcoming and so nice and so wonderful. We have met some amazing people here, and we've already connected on Facebook and emails and everything. So hopefully we'll keep those connections going. And as we talked about in one of the last sessions, being able to do some joint research and some joint collaborations on some different things, and all the ideas don't need to come from us. One of the benefits that Brian and I have that we can bring is we have experience doing with research, and we have large centers that do a lot of international things, so it doesn't even need to be with just us. As I was talking with a couple people today, the good thing to remember is we're respiratory therapists, we're not physicians, so we don't have the wide knowledge base on every system and how it interacts as much as you all do. We concentrate predominantly on the pulmonary system and mechanical ventilation and a lot of those pieces. So some of the questions you have and some of the things that we might want to dive down the road of research there, I can almost guarantee I can find one of our neonatologists that has that same question, that same concern, to create that collaboration as well. So I think it's the beginning of really a great partnership. And to start off with our last session here is weaning. We've been talking for a lot of days on everything that we do once we're intubated, or should we even intubate, and can we just stay on non-invasive? But really, what do we do once we're on there? And I know our main goal is to get off the ventilator as soon as possible, and everybody agrees upon that. And I think you've heard me say enough times over the last 3 days that yes, we want to come off the ventilator as soon as possible, but we need to know that once we're not on, there is a time point when you have to go back on too for some patients. And if we wait too long to reintubate, we can cause as much damage. And that's an area of research that still needs to be developed. And really, death and BPD can't be our only outcomes that we ever look at forever. We have to start looking at the in-between, because we get to the point where we kind of are with some things where we've gotten so good at care and preventing death that you're not going to see the drastic reduction in death, but that doesn't mean that treatment isn't still valuable for the long-term outcomes of that patient. So to our weaning part, I skipped my my slide on disclosure. You've seen them how many times? They haven't changed in the last couple of days. But we're just going to talk about some of our goals of weaning and trying to make sure we're hitting back to the basics and remembering those pieces. What are some of the strategies from conventional mechanical ventilation that have been successful, that are common, and those from high-frequency ventilation? And again, there's unfortunately, like everything else, no standard set guideline that everybody should follow on every baby that works. You kind of have to take a look at your baby and see how things are going, and really what your comfort level and your practice is. And as we've also discussed over the last couple of days, doing what you know how to do well oftentimes works the best. And when you're going to experiment out to another area, making sure you have those resources. Because there really is no data that tells us one way or the other what the best thing to do is. Weaning is somewhat of a gradual process of reducing the ventilator settings with the goal of discontinuing support. And the important part here is the goal of discontinuing support. And we found, particularly in our chronic lung disease babies, that people continue to wean even though we don't have a goal of getting them off the ventilator. they have a tracheostomy. They're going to be going home on a ventilator. We've already decided this. The parents get this. They're good with that. Why do we continue to wean? They take down their PEEP and then they decompensate and they set us back for a period of time. So if your goal isn't to get off the ventilator right now, then why are we weaning? Just let them stay stable. And part of the thing that we've talked about too over time is the big swings in oxygenation and CO2 and everything else doesn't do any benefits to the brain. So if you have a surgical process of which you need to stay intubated for a certain period of time, then maybe we should find that happy steady point and not push it until we're really ready to get off, and then you can do more of an aggressive wean. And that's a concept that's starting to come up in some of the units because of the stress that we put the baby through for all of these weaning. And we find we get to the point of, here's our extubation point and we're ready to extubate, and then the physician says, oh no, we're going to keep them intubated for another couple of days because we're going back to the OR. Well, then why did we get to this point? Why are we stressing them out? So, the main goal is that we're going to get off as soon as we hit that extubation point. We're gonna bite the bullet and we're gonna extubate them. And it's going to be after resolution or stabilization of whatever that underlying condition is. We have in the U.S. Our case managers and our discharge planners that as soon as the patient is intubated, they want to know when you're going to extubate them. And we haven't even secured the airway yet, and they're wanting them. We haven't fixed the process that made them get intubated. So we have a thought process that as soon as you're intubated, you should be planning for extubation and you should be going towards it. And I think there's a lot of things that you can make sure that are decreased to get you to that nice happy point. But you really have to make sure that whatever caused you to get intubated is resolving or has resolved or will resolve by the time frame of which you're going to extubate. And you can kind of follow two paths at the same time if you know your goals are going to get you to that same point. But it's no use extubating them if you know that they still have the same problem that's going to keep them reintubated again. And this process doesn't have to be slow. It can be quick as well, because some infants, especially if they don't have lung disease, will handle a fairly aggressive weaning process and really go off of their cues. If they're letting you wean their oxygen all the way down to 21% within a couple hours, great. But keeping within your time frames. We have some physicians that only want to wean a rate or a PEEP change once every other day. Some infants need that to happen. Some of them can handle it twice a day, depending on what the measure is. And as long as you're really watching for your indications of failure, you can kind of push it a little bit and take the child's lead instead of staying in your own structure of we only wean this every so often, and that can really extend out the process. So strategies with conventional, the main goal, really regardless of your strategy, is you want to make sure before you're starting to really wean down that you have normalization of your CO2, your oxygenation, your pH. If things are out of whack and then you start weaning down, they're not going to get better just because you've weaned them. So you don't want to wean too soon. And sometimes that really can be, you could be weaning your oxygen, but having to go up on your rate to make sure that your CO2 stays within range and whatever is normal for that patient. You want to aim for relatively low settings, decreasing your PIP or your tidal volume to whatever the normal range is for that size patient. Generally, you want your PIP a lot less than 30, PEEP less than 8. Your respiratory rate you can get down to less than 20, and definitely your oxygen less than 40%. Like Brian had said earlier, you don't have to be on zero oxygen to extubate. We know how to give oxygen well, or even give some PEEP well if you're comfortable extubating from a little bit larger of PEEP, because we do nasal CPAP very well in the infant population. If you can get the tube out and get them off the ventilator, they don't really have to be super low on their oxygenation, but you want to get them to a good point where you're not going to be putting them in harm's way and making them decompensate too much during that transitional process. And one good option to do, which I guess is one of our hands-on sessions after, and I'm not sure how often you all have used transcutaneous CO2, but it's a really good option and a good measure when you're working on weaning to help you wean a little bit more aggressively, do a lot less blood gases. If you can trend your transcutaneous CO2 number, then you can really get a good idea. Getting a blood gas to really correlate it with your first readings, because your transcutaneous CO2 won't be exactly the same as your arterial CO2, and that's something that we know, and it can be off by 10, but as long as it's always off by 10, it's used as a good trender, and that can really help you to wean down a little bit more aggressively. And really, they need to be able to breathe spontaneously. A lot of our ventilators now have pretty good support modes and spontaneous modes. They're a lot more flexible with sensitivity measures and trigger, where we can help to make them a little bit more comfortable and synchronous. So dropping their weight down, even putting them on pressure support with CPAP, to make sure that they can maintain a normal minute ventilation by themselves for a period of time. Otherwise, when you take the tube out, there's going to be a lot more problems. And as much as we can anticipate and prevent an emergent reintubation, we definitely want to do that. And then when choosing the spontaneous modes, like I said, SIMV or pressure support, making sure that your pressure support is adequate. Sometimes people add on, well, we're just going to do 5 and we're going to do a really low level. But you want to make sure that you're giving them enough if they have, especially a little bit smaller of a normal endotracheal tube with a leak. You want to give them enough to really help them compensate. If you can make sure you're monitoring their exhale tidal volumes to give them enough support to get them into a little bit lower than a normal range, at least for a period of time. We want to really look, one, to make sure they can consistently breathe, to see if they're periodic breathers, if they need to get some caffeine before we extubate them, if it's not something that's routine within your practice, and hopefully prevent a lot of things. Sometimes starting off with a pressure support level that gives you the exact tidal volume that you had before, and then slowly decreasing it by 2s to see how far they can start breathing spontaneously. And as they start doing more of the work on your own, you'll actually see they'll start overshooting that tidal volume because they don't need as much help as before, and you can really lean that down if you want to go for a very slow process for them. And oftentimes if they've been intubated for an extended period of time, you need to take a little bit of a slower route so they can help build up their muscles and their stamina for breathing. And monitoring your waveforms, we touched on them not for a very long period of time, but your waveforms can really tell you a lot of what's going on with your patient before you start to see decompensation. So really taking a look at those every time you're doing your assessments and your screening to make sure everything is going okay. If you're starting to see them really hyperventilate, maybe their minute ventilation overall is good, but if their respiratory rate is high and they're making themselves have some auto peak, then maybe their peak level isn't enough and they weren't ready to make that decrease in their peak. But don't wait until their oxygen saturations go down or we've had to be up on the oxygen for so long. Our waveforms can help us tell us that too. And just a little tweak back with the ventilator, watching them for a couple minutes and see if their breathing pattern settles out and their waveforms go back to a normalized pattern can tell you whether they really could have made that step before we see them decompensate and if they're weaning well. And then really once you get down to maintaining your breathing in those low settings, get the tube out. There's no reason to wait until the next day or the next morning or whatnot, whatever your practice is. But one of the things is trying to get it out as soon as possible. We found ourselves in a loop in the U.S. for a period of time before we had attending physicians in-house all the time because we have kind of a different structure or hierarchy of professionals in our hospitals that they didn't want us extubating when the attending physician wasn't there. Well, if they're at home sleeping that night, we have to wait until the next morning. It got to be more of an extension of care. So now we have attending physicians in the hospital 24 hours a day so that we can extubate them 6 hours sooner. And sometimes that 6 hours means a lot. It stops them from getting that ventilator-associated pneumonia or pulling their tube out themselves because we kept their sedation so low and then having an adverse event, an airway trauma because of that. From high frequency, some of the strategies for that, your starting points are kind of the same. You want to make sure that you're in a relatively normalized pattern before you start to wean down and that you've given them enough support for a period of time. Making sure that you have normal lung inflation on the chest x-ray. If you don't, you might have some problems when you start decreasing your other settings because it's been compensating for the fact that you weren't well recruited, and that could be a little bit of a problem. Really, weaning that minute ventilation down first and having the patient do a little bit more on their own. One of the things that Brian had talked about in his advanced modes talk is that in our little ones in the NICU, we can let them spontaneously breathe on an oscillator versus we really can't in pediatrics and adults. So that's a benefit here. We can see that they're starting to make some efforts and that they have that respiratory drive. But weaning their amplitude down on the oscillator, the pips down if they're on the jet, and then really starting to wean their mean airway pressure once you get down at least below about 40% FiO2 when you're starting to wean your map down on either one of these machines. And some people prefer to transition over to conventional mechanical ventilation, especially if you don't have as much experience, or if it's an older infant, to really make sure that they have that drive to breathe, putting them on a CPAP pressure support and supporting them a little bit longer to make sure that they're going to be okay and aren't going to fail when they extubate. Some people are very comfortable extubating straight from high frequency ventilation. In our conversation we had a little bit earlier, if they're less than 1,000 kilos, or they're in the newborn stage, regardless of their weight, if they're on high frequency, we get very comfortable extubating them straight to CPAP. But if you have someone who you've put on high frequency as a rescue and they're 4 months old, you might feel a little bit less comfortable about that, especially if they failed extubation. So it really depends on how many times they've been intubated, how long they've been intubated, and their age range, where some people prefer to switch over to conventional ventilation first on your weaning settings, and then aggressively coming down from there, so you can kind of get an idea as to how the infant's going to do and if they need any additional support. Extubating straight from CPAP, again, is very widely done, but making sure that you're giving them a good comparable amount of CPAP. So if you're extubating from a higher level of mean airway pressure off of high frequency, say of 8 or 10 of a mean airway pressure, putting them on a CPAP of 5 might be a little too drastic of a wean when you take the tube out. So you might want to start off with a little bit of a higher level of a CPAP. The wonderful thing too about the CPAP machines that we worked on yesterday is it gives you a mean airway pressure reading. So you know you can step down. It doesn't have to be the exact same mean airway pressure, but you don't want to really cut the support that they had in half, because you'll have a higher risk of really needing to re-intubate them. And sometimes when you are a little more conservative, you can then continue to wean a little bit better. And one of the things we don't know is our outcomes a little bit better when we don't have those little bit of setbacks for the infants. We know that the parents mentally do better if they don't have little setbacks, because we see as having to turn up the PEEP once we've extubated is not that big of a deal, but a lot of times our parents, we found, vocalize that they feel a little defeated and that the child isn't doing as well, and they're going to end up back on the ventilator when they see those step backs. And if we can give it a half an hour or a little bit longer on a little bit of a higher level and stepping down, it might not be that harmful. And really, once you go into non-invasive support, remembering what our primary goals for non-invasive support are, and when we're hitting failure there. If you're able to maintain oxygenation without going up on your FiO2 too high, you need to increase your PEEP settings. You're maintaining ventilation. Oftentimes with our infants, it's oxygenation that causes their problems, specifically when they're extubated, but making sure that they're not panting, and if they're starting to get very tachypnic, then they're going to start to have a ventilation problem as well. Making sure that they're still able to grow and handling. If they're having a hard time being touched, dealing with anything, or they're not growing, then they might not be getting worse, which is a good thing. They're just maintaining, but is maintaining that way through life what's really going to help them in the long run, and you might need to escalate support for a little bit to help get them over a hump, so that they can continue to grow and start to deal with handling and care and start to do all the normal things that the babies are supposed to start doing. So it's really important to recognize those early signs of failure and not wait until they get too far. Increasing in FiO2, if you go up by 5 or 10% for a period of time and come back down, or if it's only transient during certain times, it's really not that big of a deal. But if you're consistently having to go up on the oxygen, you might want to increase your support a little bit so you can come back down the oxygen. And sometimes it's an increase in your PEEP by 1 that really matters. Or if you've extubated or gone to nasal cannula, some of the discussions have been that some of the units are going to start some high-flow nasal cannula, and could that be a better potential option as well? That's a bit more non-invasive, but more support than a nasal cannula for these infants, and there's definitely a role there. If they've increased their total frequency by 15 to 20% from where they are before, it might not be that apparent they're breathing in the 80s, but if it's definitely an increase from what their baseline was when they were comfortable, then we need to recognize that, because that's an early sign of failure. And oftentimes an earlier intervention can help you stay on track in the long run. If they decrease their tidal volume, if you have a way of measuring that, generally if they start breathing a lot faster, their tidal volume is going down. They're still able to maintain that minute ventilation to keep them going and to keep that CO2 normal, but that still isn't a viable breathing pattern for long term. So you want to be able to help them before they start to really tire out. Definitely when their minute ventilation goes down, you've been having a problem for quite some time, or there's something more apparent going on and you really want to intervene. And looking at if you see any lung collapse, if there was a reason, or at post-extubation x-rays, if that's within your practice, or a period of time after, if they're really having lung collapse, even though they haven't shown signs yet, if there's a significant amount of collapse there, then you might want to do something to assist with that. So just kind of summarizing some of our basics and our main goals, because again, there isn't one set strategy on how for every infant in the NICU should be weaned, even per mode. You want to be able to really make sure you're keeping with your goals, recognizing your signs of failure, and titrating that experience to that infant and what they're able to do and what works for them. And that's when we'll really be most successful. And sometimes stepping down from advanced modes to conventional will work for infants that have been struggling with being intubated for a longer period of time. And your infant really needs to be ready. So re-intubating them and going through that entire process and having a period of time of decompensation, really being on the edge, isn't going to do potentially well for their neurodevelopmental outcomes in their brain, and trying to keep things as stable as possible is what potentially can really help us in the long run. And it's something I'd love to see a lot more research done on, if we can help to really maintain, make them struggle for too long and go into these dips, and see if that helps them. And that's, again, I always, when I put talks together, come up with more questions for myself, and that's the person in me. Why I wanted to go into research to begin with, is I oftentimes have more questions than answers, and wanted to be able to go and look out for those answers. So if there's any questions about weaning. Thankfully, it was the last talk. We all get to get up and move around now. Great, thank you.